So I want to talk about a few things that are going on in Washington, and then I'll talk a little bit about where I hope to help direct things to go. I'll give you a caveat before I say that, and that's that I'm on the Financial Services Committee, which has absolutely no jurisdiction over healthcare. But that has not prevented me from being involved in healthcare debates in my 3 years in Congress, and I don't think it'll prevent me in the future. So I'm trying to insert myself and use the knowledge I've gained from many of you and from a lot of other folks I've talked to about healthcare to try to make things better in America. We talked a little bit about where things stand a while ago, and I think the folks that were behind the Affordable Care Act, while well-intentioned, if they were physicians, they would be sued for malpractice because they misdiagnosed the problem. They thought the problem was access to insurance. And I say access to insurance, not access to care, because that's what they proposed was access to insurance. And in some cases, with very high deductibles on that insurance, it doesn't even guarantee folks are going to get access to care ultimately. They missed a few other things with regard to that. They missed the workforce piece. I'll talk a little bit about the workforce piece, talk about GME, we'll talk about that. And then, but more importantly, they missed the problem. The problem in our healthcare system is the problem of cost. We spend 17 or 18% of our gross domestic product on healthcare, and the closest country in the world to us spends about 12. And we need to figure out how we can build a system that can create efficiencies that will lower costs, but not do it on the backs of the providers or on the backs of the patients. So let's talk about some of the things that have happened that have been mistakes in the past. Let's talk about the sustainable growth rate. We did finally do another patch, sadly, 2 weeks ago instead of a full repeal. I favor a full repeal. I knew it was not going to be a full repeal when I saw the Republican bill pay for. The pay for was essentially getting rid of a part of Obamacare, which the Senate won't pass and the President won't sign. So I knew, I was like, oh shoot, this is going to be politics. And when I saw that about a week or two out of us doing something, I realized we might have trouble doing a full repeal. But I think there's a way for us to come together on a full repeal. As many of you know, the full repeal is much cheaper than it has been historically. Right now, it would cost less than $150 billion. I think it's $138 billion. That's real money. Don't confuse it. But it was at one point it cost $700 billion to do a full repeal. So my wife taught me a long time ago, when something's on sale, you buy. So we need to do this because it's the right thing to do. We can't have the House of Medicine living under this threat of a 30% reduction in their reimbursement on any given day when the thing would expire. And so I think we've got to do a full repeal. So we got another Band-Aid for now. That's not what any of you wanted, but as I said to the small group, the only thing worse would have been doing nothing, letting it expire, and having people have to backbill and creating some real nightmares. So we avoided that. That was, the thing I'll say about the SGR, that was a Republican bad idea. It was Bill Archer's idea back in the 90s, and it's never kicked in, but it was, so neither party has a monopoly on bad ideas. But let's talk a little bit about the Affordable Care Act and how it is increasing bureaucracy, it's increasing cost. It defined what a minimum insurance policy should be, which is driving up costs in a big way. It created more unaccountable boards like the iPad. It was loaded with tons of taxes. To make it work, they did 10 years of taxes for 6 years of spending to make it balance. So there's no way it can ever balance. And I believe we need to start over. And somebody in the small group asked me what I think is good in the AC. What would I keep and what would I get rid of? And I said, it's a 2,200-page bill, and if I wrote it, it would be about 300 pages or less. I would keep the ability for 26-year-olds and younger to stay on their parents' plan, but I would say you have to charge a premium for it because we shouldn't be giving things away free. And it is about access to insurance. And there's nothing that says that that should be subsidized by anybody's, adult child's employer. So I would keep it, but I would change it. I would also keep the pre-existing condition ban because that's what insurance is for. But I acknowledge that that will drive up cost. And I don't think pre-existing condition is the right way to solve the problem. But the things I would get rid of is basically almost everything else. I'd keep some of the prevention language too. But what I would replace it with is a much more consumer-directed healthcare plan. And I see Dr. Williams in the audience, and I've read his book, and I would advise all of you to read his book. Because consumer-directed healthcare can work. Now, we need some preconditions to make it work. We need transparency. There's no price transparency or quality transparency in our healthcare system today, or it's very limited. It's a very opaque system, and we need to fix that. We need to look at what drives healthcare costs and deal with those things. So let's talk about some of those things. 40% of our healthcare costs are driven by consumer behaviors. That is the biggest single driver of healthcare costs in our country. Yet the payment system under the Affordable Care Act forces a community rating which says everybody has to pay essentially the same or within a very small percentage the same for their cost of insurance regardless of their behaviors. If we did auto insurance like that, basically people would know we are subsidizing bad drivers. In healthcare, when you do that, you're saying to people, you don't have any skin in the game on your health. It really doesn't matter. It's the Bart Simpson model of healthcare. If anybody doesn't know what that is, it's a life of sin followed by a deathbed conversion. So we have to give consumers and patients some skin in the game and some incentive in their own healthcare. And in every other part of our economy, we use price to transfer that incentive, and we should do it in healthcare too. The next thing that drives healthcare costs is taxes. 9% of our healthcare costs are driven because of our tax policy. So, and one of the docs gave me Dr. Coburn's proposal on healthcare, which makes a lot of tax changes and creates a tax credit for people to get access to care. One of the other questions in our small group was, doesn't everybody deserve access to care? And I believe that everybody deserves access to care. I don't think health insurance is a fundamental right. It's a product, but I think we should make it affordable for everybody to get it. And one of the ways we can do that is through things like tax credits for folks that can't afford it. So that is an interesting policy idea. But when we tax healthcare, that's the other thing that we do. We tax health insurance policies and we tax healthcare. We make it more expensive. And so if you really want to make healthcare more affordable, we should be talking about our tax policy around healthcare. And the final sort of big thing that we need to do in healthcare, if we want to incent the right behaviors, is change the payment system. So we talked about a few of those ideas and thoughts in our smaller group. The payment system today has some very interesting incentives. So if you are a private practice doc and you sell your practice to a hospital tomorrow, they can bill, not on every code, but on many codes, about 150% of what you were billing yesterday. And the health care that they deliver is exactly the same. And I'm not anti-hospital, I just don't think, I don't do that in any other part of my life where I pay somebody 50% more than I paid the guy right beside him. And so we need to look at some of the perverse incentives in our payment system. The other part of the back end of our payment system is we don't pay for outcomes. And I think some portion of our payment should be based on the outcome. And there's ways to do that where you're judging the outcomes on average outcomes and judging them against like people that have the same acuity, so you're not going to incent people to only serve well patients. But I think we should pay for outcomes because when you pay for something, you create an incentive for it, you'll get more of it. And I think we need to transform our payment system to create an incentive to pay for outcomes. So those are some things that I think could really help. I didn't mention tort reform. I believe in tort reform. I sponsored tort reform in Ohio, comprehensive tort reform that had a cap on punitive damages, a cap on non-economic damages, a medical or a government standards defense. It had a collateral source rule. It was comprehensive tort reform that is now the law of the land in Ohio. And I believe in tort reform. Tort reform, by the way, drives about 7%, or lawsuit abuse drives about 7% of our medical costs. But the tort reform itself is not the end. It's not what saves the money. It's when the doctors that were doing extra things for their medical defense understand that they've got to, they can follow the regular standard of care, and they don't have to do all these other things. So it's the starting point, but it's not the ending point. You have to change the behavior of the physicians in order to save that 7%. So when you add, by the way, some of the percentages I just talked about, and let's say we're not 100% effective at any of those things, we could drive about 40 to 50% out of our healthcare cost. And that's without talking about things that I also believe in, like insurance reform. Because I know many of you fight every day with insurance companies that downcode you. And we talked a little bit about the new coding system that was delayed and some of the interesting things in the new coding system that's going to make healthcare much more complicated. And certainly for primary care folks, they're going to have to learn a lot of new things or have technology that tells them what the billing codes are. And I'm sure that helps some big data company somewhere, but I'm not sure that everything in that coding system is going to help healthcare delivery and save costs. So we need to think through some of those policy decisions as well. So that's a little bit about where I believe we should take our healthcare system. And that's not a perfect solution, but I think those ideas with transparency, with more consumer-directed healthcare, with changes in the payment system that drive individual patient behavior and encourage healthier or better outcomes. I think you would drive cost out of the system and you'd get better outcomes in the system. And I believe those things are achievable, and that's not to mention other non-political ideas like FDA reform. So more people die every day waiting on the FDA to approve a new drug than die because insurance companies don't approve their procedures. And a simple Central Ohio example in my district, there was I hate to call it new, there is a newer sunscreen technology. There's a great article in one of the Washington papers this week about it that was started in 2003, approved in Europe in 2006, 3 years into the process, that has still not been approved in the United States. This is a topical sunscreen. So today's version of sunscreens work by absorbing the sun and then you wash them off. This sunscreen works like nature. It reflects the sun. It's available in Europe. And it's still not available in the United States. And we're in 2014, 10 years later. And it has resulted in fewer deaths in Europe. Meanwhile, 12,500 Ohioans died of skin cancer last year. And this is a topical agent. There is no reason it should take 10 years and $2 billion and still not be approved. And that's an example of what's going on at the Food and Drug Administration, where I believe they don't have the appropriate guidance and measures. This thing would save people's lives. Another example, I'll give you another Ohio example, it's down in Westchester. Amylin Pharmaceutical took 6 years to get approved for a longer-acting insulin that they could do a once-a-week shot instead of 3 times a day. And it acts in such a way like an artificial pancreas, where when you need more insulin, it gives you more. it totally prevents hypoglycemia, where people's blood sugar drop and they faint and bad things happen. And it actually keeps their blood sugar level much more level. It took 6 years and $3 billion to get that drug approved. And the only change was the way it was delivered, the active release or whatever, timed release mechanism that they used. And it was approved in Europe much quicker. So Tim Ryan out of Cleveland and I, he's a Democrat, Tim's agreed to co-sponsor a bill that I'm sponsoring that will say if a drug is approved in Europe, it is automatically conditionally approved in the United States. I don't really like that long term, but we have to beat into the Food and Drug Administration that there are other places people can go, and we need to make sure they think about risk tolerances and healthy outcomes and how we can save people's lives. So the long-term thing is to create some real measures of effectiveness for the Food and Drug Administration. The real problem is they've had a lack of leadership. They've had a lot of turnover, and the bureaucrats there think they can wait out the top guy because the average tenure of the last 3 directors is less than 2 years. And that's a problem. So that's some things about where I think health care should go, and it's some examples of things that most of them aren't really partisan. I admit tort reform is not going to be supported by a lot of Democrats, but I think it works. I believe in it, and that said, it's not the biggest cost saver out there. We already talked about what was. I'll talk quickly about what I think we should do on workforce. You know, I sat on the Decision Supply and Demand committee when I was a state senator, and we see a lot of docs retiring early. We see a lot of folks who aren't really going into primary care. We also see GME slots frozen for the last 20 years. And graduate medical education is funded through Medicare, and it really has nothing to do with Medicare. That was just a convenient pot of money. This is a workforce development issue. We need to fund workforce development. There's a couple immediate bills that I'm a co-sponsor of. One would create 1,500 new residency slots. Another would change the way that we deal with our GME, especially for rural areas. But long term, we've got to create or move the funding for GME to some workforce development program, because that's what it is. We need to acknowledge that and make that hit. There were 1,000 students last year that didn't get matched with their residency, 1,000 American medical students. Part of that's because of foreign medical graduates. Part of it's because the GME slots are frozen. And frankly, there may be foreign medical graduates in the room. I don't look down my nose at foreign medical graduates. If you look at the demand for physicians that's coming, we're going to need foreign medical grads because we don't have enough medical school slots to get it done. And some of these foreign medical schools do a really, really good job. And I have no problem with them competing with our American students. Our problem is in our GME, and that's why every year I've worked to make sure we fix GME for the short term, but we've got to fix it for the long term. So that's where I think we should go on our workforce issues. I want to go ahead and open it up to any questions anybody has, because I'm sure there's things I did not cover. I didn't really hit my speech. I just spoke off the cuff because there's things I think are really important, and I think some of the great conversations we had in our small group I wanted to share with everybody. So let me open it up to anything anybody wants to ask about any topic. It can be healthcare related. It doesn't have to be healthcare, but I would suspect that most of the questions will be healthcare related. Any questions? Good. Go ahead.
Since 1997, there's been a big push to get hospitals prepared for disasters, mass casualty incidents, but we've seen a drop-off in the funding for those programs over the past few years, especially the ASPEN grants. Is there anything that's on the horizon that will get those funds back to the hospitals?
Well, you know, I am trying to get on, in addition to the Financial Services Committee, the Homeland Security Committee. That's a Homeland Security issue, but it's also a natural disaster issue. And the things that hospitals have done better is they know what their capacity is now. They know how to measure it, and they've actually moved some of the things out of the emergency room. Done a pretty good job of that, although there's still people get this in primary care in the emergency room, which, by the way, is the most expensive place to do it. I think of all our homeland security issues, those medical preparedness issues are really important, and we need to figure out how to fund that instead of funding, for example, armored cars for the local sheriffs. Because frankly, what's a sheriff need an armored car for? But there's a homeland security project that's funding armored cars for local police, and I think the medical preparedness is more important. I think it also, by the way, funds tanks, but I don't think they've done that yet, but it's authorized the way they wrote the language, I think. Yeah, well, Lima, it is good for Lima, I guess. There were a whole bunch of people that raised their hand, and you also, I think I was actually pointing at you, but he stood up, which I'm okay with. Go ahead.
Yeah, you alluded to the fact